This conference will now be recorded.
All right, good evening, everybody. Thank you, Christina, for that. I am Dr. Dan Evering, and I'm going to be doing a presentation today on the TenJet percutaneous tenotomy. And it's a specialized treatment that we can use for most kind of tendinopathies in the body. So I am just a little bit about me. Perfect. So I'm a non-operative sports medicine physician, which means I don't do surgeries, but I do practice sort of non-operative orthopedics in addition to sports medicine. I went to medical school, actually kind of local in Rowan, SOM. Used to be UMD&J, the School of Osteopathic Medicine. I did my family medicine residency at the Crozier Keystone Health Network. I also did my sports medicine fellowship there as well. Currently working with reconstructive orthopedics as of 2018. They were kind enough to give me my first job out of fellowship. And I've kind of served in a couple different roles over my sort of short career. Currently, I'm the team physician for Cumberland Regional High School and the Cumberland Regional School District. I also have covered teams like the Philadelphia Union, Philadelphia Soul, Atlantic City Blackjacks, University of Delaware football, and basketball, in addition to a few other high schools in the past. And as a non-operative physician, of course, I don't do surgeries, but I do a bunch of other procedures, including injections and then the TenJet, which I'll talk to you about today, to try to help with chronic conditions or even acute injuries. So I'm just going to kind of go start from sort of square one. So first thing, I just want to briefly go through tendon anatomy. I don't mean for this presentation to be sort of too scientific, but I think it just kind of helps to understand the structure of the tendon and why it can be slow to heal and difficult to get better. So tendons are sort of dense, connective tissues. They don't have a lot of sort of blood supply, and they're kind of like these little fibrils you can see all the way down here. It starts out as this one little fibril made by a single cell, and then it just kind of continues to sort of wrap itself in other fibrils as it kind of goes up. And each thing gets kind of packaged into another thing, which gets packaged into another thing, kind of making this sort of firm, but still kind of an elastic tissue that does a very unique function in the body. And each tendon fiber extends the entire length of the tendon, which is unique to tendons and ligaments. Tendon anatomy. So, the tendon bone interface, I think, marks sort of the site where collagen fibers sort of enter the bone, and it becomes kind of continuous with the bone. So there's this sort of mesh point, and that's called the Sharpie's fiber area, where the tendon stops being tendon and actually kind of merges with the bone, which allows the tendon to do its function, which is sort of move the joints of the body. The vascular supply, like I said, there's not a lot of blood vessels or blood supply within the tendon itself. It's an avascular structure, but there is some blood supply at the muscle tendon junction, where the muscle kind of starts to turn into tendon, and then at the tendon bone junction. And then there's a covering of most tendons in the body called the mesotendon, which can supply some small blood supply in the middle of that tendon. And then nerve supply at the same areas. Nerves can kind of come in and innervate each tendon. The nerves of tendons are usually sensory in nature. They kind of provide proprioception and mechanical reception. So basically, it kind of tells the brain where the tendon is and how much force the tendon is under. To be honest, there's not a lot of sort of pain perception in the tendons. So just tendon injuries in general, I mean, there's really two types to kind of worry about. The one I think that most people worry about are acute injuries. You can see Kobe Bryant tearing his Achilles tendon. It's sort of just a common example of basically mechanical forces exacted on the tendon kind of reach sort of a critical or maximum level. And when the tendon cannot handle it, it eventually ruptures just like any other structure will. And then chronic injury, which is much more common, and some of the things that I think we are more adept at dealing with from a non-operative standpoint are injuries that sort of occur with repetitive strain, repetitive loading of a particular tendon. over time that kind of leads to this chronic sort of breakdown, which then leads to pain and is why usually people come in to see me. So that's what this sort of lecture is going to be focused on today. So just chronic tendon injuries in general, studies kind of have shown that in cases of chronic tendon pain, the sort of pathologic lesion is sort of typical of a more degenerative process than an inflammatory process. So degeneration sort of occurs in areas of diminished blood flow. And if you remember, tendons don't have a lot of blood supply. So the characteristic pattern that you see is sort of this atypical granulation-like tissue that kind of comes in and replaces the fibers of the tendon over time. And when you kind of look at it under a microscope, even though the tendon can feel inflamed and feel very painful, there's actually no inflammatory cells typically present in an injured or chronically worn tendon. And that's an important distinction to make, because as you sort of go along the treatment algorithm, a lot of things you would sort of just think of in your head, oh, let me get rid of the inflammation, or things that would normally help with inflammation for other injuries don't necessarily help with tendinopathies. So the observations, of course, suggest that mechanical overuse play an important role in the pathogenesis of tendon lesions, and not necessarily things like inflammation, swelling, like we would typically think. So I just going to go through a couple of the sort of more common tendinopathies through this lecture before we kind of get into the TenJet, just so you can understand what we're trying to treat and what the TenJet is able to do. So I think the first one, and probably one of the more common ones, is rotator cuff tendinosis. And I use the phrase tendinosis. You'll see that throughout the lecture, just because it's kind of a shift in wording and verbiage to sort of illustrate a shift in the thinking behind the process. So term like tendinitis is something that is still very commonly used and has its place, but we're kind of switching to the term tendinosis because it's really not an itis. It's really not inflamed. Most of these injuries don't involve, like I said, big inflammatory responses. It's more of just this chronic wear and tear that leads to a change in the tendon structure without inflammatory cells being present. So changing the word kind of helps us change the way we think about it, which hopefully helps us change the way we treat it long term and give people, and giving people better options moving forward. So just in rotator cuff tendinosis, the muscles of the rotator cuff kind of contribute to the motion of the shoulder. And if you take a look, see if this works. Here we go. So if you take a look here, this is the back of the rotator cuff. So this is the infraspinatus muscle that kind of comes across the back of the shoulder and attaches right here at the sort of tip where you can kind of feel on this side. This is the front of the shoulder. So this is the subscapularis tendon right in here. Right in here, that kind of gives you the front aspect of the rotator cuff, and you can see this is sort of a common area to have some tendinopathy. The bicep tendon kind of sneaks underneath that subscap tendon as it kind of inches towards the back of the shoulder. And so when this tendon is worn, the bicep tendon then becomes more mobile and then is prone to getting inflamed just from mechanical forces as well. And then up top here, you see the supraspinatus. This is one of the main tendons of the rotator cuff, probably the one everybody sort of associates with. And so these three muscles, in addition to the teres minor muscle, make up the bulk of the rotator cuff tendons and muscles. And they mainly function as stabilizers around the shoulder. So they do sort of move the shoulder kind of in and out and then up and down. But mainly what they do is they work together to, as the supraspinatus tendon wants to sort of lift the shoulder, it just really doesn't lift the shoulder by itself. It acts as more of a fulcrum, and it actually pushes the shoulder down so the deltoid muscle can lift it up. And the deltoid muscle is what you see out here. And as it's doing that, the infraspinatus and supraspinatus or subscapularis muscle, they sort of hold the shoulder in place so that it doesn't wiggle, forward and backwards. And then as you're using your infraspinatus muscle to sort of externally rotate the shoulder, you also get the supraspinatus and the subscapularis tendon holding the rest of the shoulder in place so that it doesn't sort of wobble and the joint is stable. And when any of those is torn or worn out, you can have a lot of wiggle and a lot of sort of muscle imbalances that develop in the shoulder. Okay. So rotator cuff disorders, frequently develop in people who just place excessive stress on the shoulder. Usually it's sort of repetitive overhead motion, overhead use of the arm. Weakness of the rotator cuff muscles can predispose you to having shoulder instability, like we kind of talked about, since one of their main functions is holding the joint in place. And because of that sort of instability, you can get more movement of the shoulder, and then that puts the rotator cuff under a lot more stretch, which can lead to more dramatic injuries like basically rotator cuff tears, which we ultimately try to prevent. So there's two kind of theories that sort of explain the development of rotator cuff tendinopathy. The first is the intrinsic, theory, which basically says that it's the cuff or the tendon itself from being overused and sort of being sort of used in the wrong way that sort of makes itself weak, creates this avascular critical zone in the tendon that kind of gets broken down, and then over time it gets worse and worse, which kind of predisposes you to more injury. Then the extrinsic sort of theory basically says that it's not the rotator cuff itself that's doing it, it's something else that's pressing on or altering the rotator cuff that causes sort of this breakdown. This could be structures like the acromion, which is basically part of the collarbone, coracoid process, something, from an arthritic shoulder like an osteophyte or a bone spur. Something is causing abnormal rubbing and abnormal movement of the rotator cuff. In reality, both of these can be true. And honestly, depending on the structure of the shoulder, some of the stuff you may just be born with that can kind of predispose you to having these issues. And sometimes it's just the tendon itself that fails. And we see both, clinically. So kind of moving on to sort of lateral epicondylitis, commonly known as tennis elbow. This is most common in people aged 30 to 50. Men and women are equally affected. And this is more of a non-athletic injury than anything else. So it's called tennis elbow, but rarely do people get it from actually playing tennis. It's just the muscles that are involved in holding a tennis racket that can be involved in this. So that's where it kind of got its name. But it basically is an irritation of the tendon origin at the extensor carpi radialis brevis, basically the muscle right here. Let me get the spotlight back on so you guys can see a little bit better. Right here, which kind of attaches to the lateral epicondyle. But what you can also notice is that the common extensor tendon, there's a huge aponeurosis that forms from multiple muscles that kind of control the hand and the wrist that attach all at kind of one spot. And so if any of these muscles are out of whack or weak, it kind of throws the whole structure off, which leads to this, again, chronic overuse, chronic wear and tear. And because the blood supply is so low, these tendons don't typically heal very quickly. And people can't really stop what they're doing. So over time, that weakness kind of develops into partial tears and sometimes even complete tears. And the pain usually comes from this sort of myotendinous junction where this white stuff kind of meets the pink of the muscle. Those are where the usual pain receptors usually are. And so again, we think of this as more inflammation because when you touch it, it really hurts. But if you were to look under a microscope, or even if you were to open the elbow up, you wouldn't see a lot of swelling. You wouldn't see a lot of anything else except thickened, sort of irregular tendon tissue. So this graph I think is nice because it kind of illustrates what we've been sort of trying to get people to understand for a couple of years now. In that, this red line here illustrates the corticosteroid injection treatment path. So a lot of times people with tennis elbow do end up getting a cortisone shot, and I think it does have good value because the success rate in terms of pain relief and getting back to normal function, and as you can see here, this is 0 months, 3 months, 6 months. So in the first 3 to 6 months, cortisone injections give people an extraordinary amount of relief. You see the blue line, which is if we did absolutely nothing at all. And then the green line is if we did the standard of care, which is physical therapy. So initially, the sort of green line gives you a little bit of a bump over doing nothing, but it's not anywhere near what cortisone is. What we've noticed is that after 6 months, the success rate of cortisone drops completely. And these are people who have just had one injection or have done one round of physical therapy. This is not sort of you getting multiple injections over 6 to 12 weeks, or excuse me, weeks. I apologize, not months. And what we see is at the 3-month mark, the cortisone and the wait and see method kind of intersect. And that basically tells us that cortisone shot, once it wears off, you're kind of back to square one. With physical therapy at the 3-month mark, you're still ahead of where you would have been had you just sort of done nothing at all, which is why it has become the more favorable standard of care. As you sort of extend that out into sort of half a year, 6 months, and then a full year, 52 weeks, you see that cortisone actually does worse than if you just did nothing at all, and definitely much worse in physical therapy. So because of this trend, and it's been reproducible in numerous studies, we have sort of tried to move away from giving cortisone shots unless it's absolutely necessary. And this is one of the main reasons why a lot of physicians have moved away from doing more than one cortisone shot for tennis elbow. Obviously, every situation is a little bit different, but again, this also just kind of goes to show that while cortisone can help with pain, it doesn't help treat the underlying issue because it's not an inflammatory issue, and can actually make the condition worse because it sort of limits the ability of the tendon to do any sort of healing. Greater trochanteric pain syndrome is basically tendinopathy of the hip. A lot of people may have heard of trochanteric bursitis, which is sort of like that bone at the sort of edge of the hip that you kind of can push with your finger. A lot of times people, when this gets inflamed, that bursa sac gets inflamed, you can have difficulty laying on that side. Sleeping can become a problem, walking, even sitting. But this syndrome, this tendinopathy is a little bit different. This is more of a tendinopathy, which means the muscles are involved. And again, there's no inflammatory tissue. There's no swelling of that bursa. And a lot of times in the MRI, that's sort of seen as well, even under ultrasound exam. Sometimes you can have them both together. You can have bursitis and tendinopathy together, but it's very important to make sure you understand which one you're treating, because again, the treatment is a little bit different. So for the tendinopathy, muscle imbalances, just like we've talked about with the shoulder and the elbow, kind of lead to overuse. The main culprit is gluteus medius, and it's one of the muscles that kind of attaches directly to the greater trochanter. And if that muscle is weak, it kind of can lead to imbalances and obviously pain long term. And that usually happens because the tensor fasciolata, which is a very strong muscular tendon on the outside of the hip, never really sort of gets weak. It actually continues to get, if anything, gets stronger as it scars in. And that puts a lot of pressure on the other muscles if the gluteus medius doesn't hold up. So what people normally see is, this pain gets worse with lying on your side, with walking for a while, like sitting for a while, like I mentioned before. There are 4 muscles involved. So the gluteus maximus, which is the main, sort of butt muscle, and the tensor fasciolata, they sort of attach to this strong IT band. And then the gluteus medius and the gluteus minimus underneath that attach directly to the bone. So up to 25% of the general population can have some version of greater trochanteric pain syndrome in their lifetime. So this just kind of illustrates what I was trying to talk about before. You see out here, here's the gluteus max and the tensor fasciolata muscle. They kind of attach to this really sort of strong connective tissue called the IT band or iliotibial tract. And that goes all the way down past the knee. And that forms basically a really strong sort of structure that kind of keeps the hip in line, allows you to sort of stand on one leg without having your hip kind of wobble or buckle. And this normally, as you can see, is almost all tendon. So it usually is not innervated with any blood supply or muscle. It can get fibrotic and kind of get scarred in, but typically gets tighter as it gets overused. And then you see the gluteus medius muscle and minimus muscle sort of in the back underneath the gluteus right here that attach to the bone. And these are the muscles that can really kind of be sort of thrown out of whack when you have greater trochanteric pain syndrome. And these are the muscles that I typically treat with the TenJet procedure. So just two more tendons to kind of go through, and then we'll talk about the TenJet procedure. So patella tendinitis, another very common tendinopathy, and this is basically the tendon that forms over the kneecap. So it starts out as the quadricep tendon at the top part of the kneecap, kind of creates this sort of covering over the kneecap, and then continues to be the patellar tendon. So it's thought of as really one long kind of tissue structure. But it is treated as two distinct tendons where you have the patella tendon down here and the quadricep tendon up here. But both of those kind of form this sort of band that tries to keep the kneecap in place, but also acts on the knee and creates flexion and extension for the knee. So the patella tendon is a pretty large tendon overall, measures about 5 centimeters. It's almost all tendon. There's sort of no real muscular junction from the kneecap down to where it attaches to the lower leg on the tibia. It's about 3 centimeters wide at the top, and then it kind of gets a little bit narrow at the bottom, and it's about half centimeter thick. So all in all, it's one of the larger, if not the second largest tendon in the body, and is at a sort of real big disadvantage because it has almost no blood supply to support it. So commonly referred to as jumper's knee, patellar tendinosis, and can result from micro tears or just kind of that wear and tear that we talked about before. A lot of times you'll see tears right where it attaches to the kneecap or right where it attaches to the tibia down below the lower leg. You rarely see tears in the middle. Usually if it tears in the middle, it's going to be a complete tear, and that will typically require surgery. And then the last one we'll talk about, the Achilles tendon. This is the largest and strongest tendon in the body. It basically acts as the main sort of plantar flexor, which is basically allows you to put your foot on the gas pedal kind of thing. So it is a conjoined tendon of both the medial and lateral gastroc muscles and the soleus muscle. Basically all the muscles in the calf kind of form this one long tendon. And it's about 15 centimeters long. So the unique thing about this tendon is it does not have a tendon sheath. It's kind of just enclosed by this sort of paratendon sort of capsule. So it also lacks a lot of blood supply in the middle, and it kind of attaches all the way down to the heel. So it goes from about like the sort of mid to lower mid calf all the way down to the heel. Achilles tendinopathy, again, chronic posterior ankle pain and heel pain, worse with activity. There's two kind of types. So there's non-insertional, which can sort of be this aching pain above where it attaches to the heel. And this is sort of found more in athletic people, runners mainly, or just sports that involve a lot of running. And then insertional tendinopathy is definitely more common overall and more common in people as they age, and the tendon sort of degenerates again, just because this is an area where the blood supply can be pretty minimal, and it's going to set you up for issues with this chronic tendinopathy in the future. People commonly kind of localize their pain to the midline, and then symptoms occur even when the tendon gets really inflamed. Symptoms can even occur at rest without you having to actually do anything. And of course, the biggest fear is that, as this Achilles tendinopathy continues to worsen and the pain gets worse, you're at risk for an Achilles tendon rupture, which is an awful injury to have altogether because the recovery and treatment options are a little tough. So that's just sort of a brief overview of some of the common tendinopathies. By no means is it sort of all we do or all we can do with the TenJet, but I think it's the bulk of what we normally see. There's other things like hamstring injuries and some other things that we kind of can help treat with the TenJet. Plantar fasciitis would be sort of another common thing, but I think from a tendinopathy standpoint, this is the bulk of what my practice is. And I don't want to talk for Dr. Holmes, one of my partners, but I think a lot of the bulk of what he sees as well. So treatment options that are not the TenJet, right? So most commonly we tell people kind of rest, use some anti-inflammatories to help with the pain. It doesn't help with healing, but it can help you sort of get through the day. Modify your activity, right? So you've heard, I'm sure, docs say it in the past, if it hurts, don't do it, which is not always easy, but something that I think does work in the right situation. Physical therapy for all of these issues is sort of the first line treatment. Even when it comes to the TenJet, we would never sort of jump right into it because physical therapy works for a lot of these issues in the long term. And then bracing, taping, orthotics, things like that. If we need to, we end up doing a cortisone shot to kind of help with pain and help you. Usually I use it to help you get through physical therapy or get through some sort of rehab program. Platelet-rich plasma is a different type of injection altogether, kind of in our biologic section that we do for specialized cases and treatment options that we think might help. That's where we take sort of the growth factors out of a patient's own blood, and we were able to extract them from the blood using a specialized kit, and we put that right into the tendon under ultrasound guidance to try to stimulate healing and give the growth factors that the tendon can't naturally get because there's no blood supply. We give it right to the tendon and hope that they sort of interact with the tissue and make it stronger. Dry needling and then percutaneous tenotomy. Ultimately, some of these cases end up getting surgical repair or surgical tenotomies, but we try to avoid that as best we can. So now we'll talk about the TenJet. So the TenJet percutaneous tenotomy, basically percutaneous just means through the skin. There's no long incision. The tendon is never visualized. Everything is done under ultrasound guidance. And tenotomy just means cutting away parts of the tendon. And in this case, it just means cutting away some of the scar tissue. So the TenJet is a product of Hydrocision. Hydrocision is a company that makes it, and they do a good job of sort of supporting us in the ORs where we do it. So they developed this specialized probe that really uses high velocity, sterile saline. It does not have a blade at the end. It uses something called the Venturi suction effect with this high velocity saline to sort of remove the scar tissue, the sort of tendinotic tissue that kind of forms over time and can lead to the weakness and lead to ultimately the pain. And it does it, again, like I said, under ultrasound guidance. The key advantage is that the TenJet probe doesn't really have the strength to cut through healthy tissue. So it's able to differentiate between the sort of scar tissue and good tissue just based on the settings that you use. But even if you maxed out the settings, you really couldn't do a whole lot of damage to healthy tendonic tissue, which again makes it a nice, safe option for sort of getting rid of just the tissue you want, which is just the scar tissue, and leaving behind the healthy stuff to allow it to heal. It's a little bit different from other products that people may have seen in the past. There's a popular one called the 10X probe, which uses ultrasound, sort of high frequency ultrasound technology to kind of do the same thing, which basically liquefies and sucks out the tendinotic tissue. I find that does have a small risk of sort of increased damage to the surrounding tissue, which is why I do not use that anymore. I used to use it in the past, but I'm much more partial to the TenJet probe now just because of the safety profile. So some highlights of the TenJet. It's covered by insurance, which is, I think, a big thing for a lot of people. Definitely less invasive than a surgical procedure. The incision is very small that we use, just big enough to get the probe through. Probably a little bit bigger than a standard sort of needle. A shorter recovery time just because of the minimally invasive nature of the procedure. Some people actually do use this in open surgeries, but for the most part, we always do percutaneous surgeries or percutaneous procedures. It does provide definitive treatment, right? So this is one of those where cortisone shots you may have to get multiple times, but this is sort of a definitive one and done. You get this, and typically when it works, you are good to go forever. Not to say you can't hurt it again, but this is not something that we look to do like once every 6 months or once a year. This is definitive treatment for your tendinopathy. It also works for calcific tendinitis, which is a big thing. Mostly we see that in the shoulder. These little calcium nodules form within the rotator cuff and can be extremely painful. And the TenJet probe is strong enough to liquefy and suck out the calcium nodule as well. again, while not harming the normal rotator cuff tissue. The procedure itself is pretty quick. It takes about 10, maybe 30 minutes to complete. Usually we do it in an outpatient surgery setting just because they have the probes. But theoretically, it could be done in the office if the probes were available. Patients can remain awake. A lot of this can be done totally under local anesthesia. And this is helpful for people who have a lot of medical problems or take a lot of medications or have had bad reactions to anesthesia in the past, or are just worried about going under in general. This kind of makes a TenJet an extremely safe option for people, and for people who may not be great surgical candidates. So the recovery period, this is sort of another highlight, kind of like we talked about before. Recovery is always going to be dependent, and it's dependent on not just the patient, but what tendon is involved, and then how bad the pathology is, right? Are we dealing with just a mild tendinotic tissue, or we're dealing with a partial tear or a significant tear? And those things kind of dictate how long it normally takes to get back. But on a typical sort of case-by-case basis, usually I perform these procedures, and then you follow up in the office in 1 to 2 weeks. We kind of take a look at you. In the first sort of 1 to 2 weeks, it's just rest and pain management, which is usually maybe some anti-inflammatory, some Tylenol, and mostly just some ice. And we do encourage gentle range of motion for most of these. Most of my patients do not require any sort of narcotic therapy, even the night of or the day after the procedure. Rarely do I, even give like a tramadol. Sometimes I'll give a Tylenol with codeine, but most people do very well with just ice and kind of rest. So the first 1 to 2 weeks is just sort of gentle, kind of getting back into the swing of things. And then at that point, we kind of make a decision on how we want to rehab and strengthen the tendon that we've treated. So sometimes it's formal physical therapy. Sometimes it's just a few exercises at home. And we kind of, it's all patient dependent and sort of how bad the pathology is and where you kind of end up after those first 1 to 2 weeks. That kind of dictates, how aggressive we are in that sort of rehabilitation phase. And then, in the 7 to 12 weeks after, it's just a gradual return of, full activity. And we expect most people to be sort of back to near normal, depending on the tendon that we treat and how bad the pathology was. We expect most people to be back to normal in 3 months. So return to work is also based on the individual symptoms and mainly a job function, but most sort of office jobs or sort of sort of labor or non-stressful jobs, they can actually go back to work, maybe with some modifications in the first 1 to 2 weeks. And then jobs that require a little more heavy lifting, jobs that require a lot more repetitive motion, especially for things like the shoulder and the rotator or the elbow. I may hold them out a little bit longer just to allow the tendon to heal and get a little stronger before kind of putting it back under that repetitive stress, so we don't have a setback or we don't have any issues. And then this last slide I think is helpful because it's really just a quick video on the TenJet procedure. So it kind of goes through everything and kind of gives you a look of what the TenJet does in action. So I'm just going to play that for you guys, and then we'll take some questions.
TenJet is a fluid jet system designed for percutaneous tenotomy of the shoulder, elbow, hip, knee, and Achilles tendons, as well as the plantar fascia. TenJet technology utilizes a supersonic stream of saline to remove diseased tendon tissue while preserving adjacent healthy tendon. The procedure is performed in a sterile outpatient environment. The patient is first prepped with chlorhexidine or Hibiclens. Diagnostic ultrasound is used to identify the diseased tissue that will be targeted for removal. The diseased portion of the tendon can be readily identified, most often as having a dark hypoechoic appearance or possibly mixed hyper and hypoechoic. After ultrasound identification, installation of a local anesthetic is applied in the area to be worked on. The procedure does not require sedation. A small stab incision is made with an 11-blade scalpel in order to introduce the TenJet needle into the area of pathology. TenJet delivers a supersonic stream of sterile saline that is forceful enough to debride less dense, diseased tissue without negatively affecting healthy tendon tissue. The force of the saline creates a localized vacuum called a Venturi suction effect. This allows the saline and resected tissue to be efficiently drawn away from the surgical site. Once positioned in the diseased region, the TenJet needle is activated and manipulated in a pistoning fashion until satisfactory reduction of the hypoechoic appearance is achieved. The incision is closed with a steri-strip and a tegaderm dressing. The joint is wrapped with a compressive bandage. TenJet provides many of the benefits of surgical removal of pathology in a needle-based conservative approach. For more information, visit www.tendonpain.com.
All right. So, any questions? I know that was a lot of information, but let me check see the message box here. All right.
Dr. Evering, I wanted to thank you again for the informative presentation you gave us tonight. I think there is still somebody with us. Did you have any questions that you wanted to ask Dr. Evering? You can go ahead and unmute yourself if you wanted, or you could go ahead and type it in the chat box. Oh, we got something.
So the question was, how long has the TenJet procedure been around? That's a good question. So actually I had to do a little research and kind of putting this together, but it actually, I think, has been around about 5 years or so. It was sort of allowed into the US and then slowly kind of, came into favor. I think in this area, I think 2016 was one of the first times it was used in sort of South Jersey, sort of Philly area. And actually, one of my partners, Nate Holmes, was one of the first people doing it in this area as well. So I'm going to say about 5 years and kind of available in the US.
All right, well, if there's no other questions, Dr. Evering, I wanted to thank you again for your time this evening, and thank you to those who have joined us. And I guess we'll call it a good night.
All right, thank you, Christina.
Thank you. Have a good night.
Take care.